Ductus venosus is a very, very small vessel which is not seen on grayscale ultrasound. Very small. But if you are in complete mid-sagittal section, it is somewhere in between. Please pen it down. It is somewhere in between the cord insertion up to the fetal heart. Point number one. Point number second, there is a turbulent flow. And if I can pick that turbulency on ultrasound, I mean on Doppler, I will easily pick the ductus venosus. Otherwise, I will keep on struggling for years to get this ductus venosus. Now, this ductus venosus is having a flow, which is the forward flow like over here. In forward, when I say forward flow, I mean I am having this S wave going up, then this D wave and this A wave also going up. And over here, I am having the baseline. So this A wave is well above the baseline. This is the triphasic normal flow. I told you that if you can pick that turbulency, how you can pick that turbulency? Now see, this is the cord insertion. This is the umbilical vein over here. Okay. This umbilical vein, and this is the heart. I told you that it is in between the cord insertion up to the heart. So can you see the change in the color in this area?
Because of velocity.
Because of the turbulency and high velocity. So if you can pick the change in the color, change in the color can be, here it was, now pay attention, see over here. Let me erase all this over here and see to yourself. Now see, here I am having a red and here I am having some whitish top up on the previous red. So this is the ductus venosus. This part is the ductus venosus. Done. Now, I will be taking the gate and putting onto this ductus venosus. I will be able to see this type of flow. See again over here. See again over here. Over here, I am having red over here. This is the red. This is the cord insertion over here, and this is the heart over here. This red is, lighter over here. I will say this is more of the orange color over here. So the change in the color.
So before the umbilical vein joins the IVC, there is a ductus venosus.
Right. Now, the sample gate, how much the sample gate has to be? Sample gate has to be not more than 1 millimeter. Sample gate, when you are taking the flow, it should not be this one, this sample gate. It should not be more than 1 millimeter, because if I am keeping it wide, this sample gate, if I am keeping it wide, I am actually hitting into the vessel, which is not actually adjacent vessel plus 2. And adjacent vessel is there. No hepatic vein. Yes, there are many hepatic veins. So actually, I am in the hepatic vein, and hepatic vein flow. Now try to understand the hepatic vein. This is very important point. Hepatic vein flow is looking like this. What is difference between the DV and the hepatic vein is that in hepatic vein, the A wave is reversed. I will not say reversed. In going below the baseline, that is normal for the hepatic vein. But if I see this type of flow in ductus venosus, is that normal? Is that normal?
It is abnormal.
It is abnormal. Now see what is happening. If your gate is wide, you are thinking that I am taking flow from the ductus venosus, but your gate is automatically in the hepatic vein, and if it picks flow from the hepatic vein, what it will show you? A reversal of A wave. A reversal of A wave is normal for hepatic vein, but it is telling me if I am in ductus venosus, I am having a reversal of A wave. What that means? Fetal acidosis. Then a report will come to you. Madam, there is fetal acidosis. You will rush to OT and you will take the baby out, and there will be no signs of acidosis. Is that not happening?
Yeah, it is.
This is happening. So this is happening because I am unintentionally hitting into the hepatic veins, thinking that I am in ductus venosus. Now question, how I can differentiate for our viewers, whosoever is with me. You think that if I am in hepatic vein flow is showing me a reversal component, and that is abnormal for ductus venosus. How to differentiate a ductus venosus flow, abnormal ductus venosus flow from a hepatic vein flow?
By
Think.
waveforms.
No. Waveform is telling me that I am having a reversal of flow. How to differentiate that I am not in the abnormal ductus venosus, but in a hepatic vein?
Okay.
Only one thing will differentiate, and that is the velocity.
Velocity.
Only one thing, that is the velocity. You are having a velocity scale over here, and you are having at baseline a 0, then 10, 20, anything. Okay. So this is the velocity scale over here. This is the scale. This velocity, if it is a ductus venosus, will be about 80, 70, or crossing 100. But the hepatic vein flow, the S wave, the top, will not ever go more than 50. Even if I'm having an abnormal ductus venosus, mind my words, abnormal ductus venosus, this S wave will not drop. It will always stand at about 80, if not more than 100, even if it is abnormal, but no hepatic vein will touch 100. So this way, if you are having now the point, if you are having a report, madam, if you are having a report of abnormal ductus venosus, there is a picture enclosed, right? You see to yourself, if I am having more than 100 or less than 50. If I am having somewhere at 100, and that radiologist or whosoever is doing ultrasound now for you, give him a call. You are hitting an hepatic vein and sending a patient to me with an abnormal ductus venosus, then he or she will open the book and will read. Actually, it is you who has to demand the things from that doctor who is doing. So this is the importance of knowing things. And now you are having a machine. Why not to do yourself? Why to depend on that person who is doing ultrasound for you? Now, see, this is how the ductus venosus flow is looking like. Normal. This is normal. Now, what is normal over here is that this A wave, this is the A wave. Now see, this is S, then again going forward, and this is the A wave. This A wave is well above the baseline, right? And this is abnormal DV, where I am having a reversal component. Reversal of what? Reversal of this A. Right? Now, if I will see for this, try to understand, I am having a scale over here. 0 will be written over here. This is S over here. This is S. Okay? This is S. This S has to correspond more or equal to 80. Somewhere at 80, if it is true DV.
Okay.
But if this is not 80 over here, but a 30 or a 40 over here, and your radiologist is giving you an abnormal DV, and you are seeing that the peak systolic velocity is just 30 or 40, what is this then? What is this?
Abnormal ductus venosus.
No, the velocity range is 30 or 40 only. Hepatic vein. So this is actually a hepatic vein which is already taken by that doctor for an abnormal ductus venosus. Now, have you not seen the cases where it was written that abnormal ductus venosus and rest of vessels were normal? How is that possible? That fetus has landed into acidosis with no signs of hypoxia from other vessels. So here, what we are doing, we are not taking this DV for acidosis, but we are taking this DV over here if abnormal for some cardiac defects over here or chromosomal abnormalities. So there are cases with this abnormal DV. This DV over here, don't get confused. This DV over here is not taking, we are not taking this DV for fetal acidosis, but we are taking this for some, chromosomal abnormalities, because there is a risk. There is a risk to have the chromosomal abnormalities if I am having an abnormal DV. So higher is the risk with this abnormal DV over here. Okay. So abnormal first trimester ductus venosus blood flow is a marker, try to understand, is a marker of cardiac defects, is a marker of cardiac defects in fetuses with normal karyotype and Nuchal translucency. So again, repeating, we are not taking this DV for the fetal acidosis, but for this purpose over here. So these are some pictures of normal versus abnormal DV flow. Over here again, you are seeing that this A wave is well above, and over here I am having a reversal component. Now see, over here, this A wave is touching the baseline, and it is not crossing it. This is again abnormal. This is again abnormal when it is touching the baseline. And over here, I am seeing that it is not only touching, but going to the other side over here, also going to the other side. This is, of course, the abnormal DV. So over to you for presenting the live cases of this DV, of this level 1 as a whole. So these are some cases where we are taking this DV. Decrease the mute this. So the basic important point is that your scan plane has to be complete mid-sagittal, and all the things. Over to you.
Actually, the scan plane has to be mid-sagittal, and three main things we have to see: Nuchal translucency, and second thing is ICT, and third thing is ductus venosus. Nuchal translucency has to be taken in mid-sagittal plane, and fetus should be in the proper position. It should not be vertical, and it should be taken from 11 to 13 plus 6 weeks of pregnancy, because after that the incidence of abnormal fluid accumulation decreases. Then ICT is basically a fourth ventricle which is above the cisterna magna, and it should be taken to detect any spina bifida in the fetus. And the next thing which is taken, very important thing, is ductus venosus. As you have studied the fetal circulation, and our Doppler courses also shows us that what is ductus venosus. When the umbilical vein joins the IVC, before that a structure comes, that is ductus venosus. Ductus venosus is a narrow structure which increases the velocity of the flow. So any reversal of waves in the ductus venosus or any type of abnormality in ductus venosus indicates any cardiac defects. So this was in short or in brief about all the components of Nuchal translucency. And basically in Nuchal translucency, we have to see the nasal bone properly in the mid-sagittal section, and there should not be any hockey stick appearance, and it should be a midline section, and nasal bone should not be confused with the tip of the nose, and nasal bone is separately seen, and a hard palate is also seen. And so this was some briefing about the Nuchal translucency.
So if you are having any question, you can write to us if you are seeing this offline. And if you are right now online with me on Zoom, you can write your question. You can post your question in the comment section. So concluding, and keep an eye on the chat box. So concluding this level 1 is not difficult condition. Only one condition apply. Condition is that you should know that what section you are in. You should be in a complete mid sagittal section. Only and only complete mid sagittal section will show you all the components of the level 1. Otherwise, you will struggle here, there. Don't do hanky panky jobs. See for the mid sagittal section. Try to get the mid sagittal. Forget about nose. Forget about knuckle translucency. Forget about ductus venosus. Try to get the mid sagittal section only. And once you got the mid sagittal section, your nasal bone will pop up and all the components of will pop up. So the basic important point is, while taking the knuckle translucency, forget about the components of the knuckle translucency. See for the section, and if you are in a complete mid sagittal section, the required things will pop up on the screen. And there's a saying, eyes can see what mind is knowing only. If you are knowing what wire is this ICT, what this ICT is, wire is that, then you will see on screen, yes, it was there. It is actually always there. This ICT is always seeing you when you are scanning, but you are not able to see because your mind is not knowing it. Now, from tomorrow onwards, you will try to get this ICT in at least 10 patients. And once your eyes will catch this, and if obliterated or absent, then you will say that, oh my God, there can be chances of, spina bifida. Then why not to insert a probe over here and try to get the spine? Because when you are inserting a probe, you are getting a better picture of the fetus, and you will see that there is actually a spina bifida. And I pray to God that if you in that patient there is spina bifida, you pick it as early as possible and send the case to me, and I will be more than happy to see that. Okay. So Anna, do I have any question? Okay. Thank you very much. God bless all of you. This was a very short class of this level 1. I hope that you have enjoyed the session. Thank you very much.